defects. There were also some of them which are not included in this group that I operated in ankle joint. So you can either use the microfractures with Hyalofast, as you can see here, or you can aspirate the bone marrow. So I was not spinning the bone marrow, I was not manipulating. I was just once the implant was inside the defect, I was just loading the implant with the fresh aspirated bone marrow, making it available to clot inside the defect. So I'm going to show you a couple of patients, starting with the easy case, 15 millimeters diameter chronic defect on medial femoral condyle. As you can see it here, this is sagittal view showing the defect here. This is another coronal view, and this is 6 months post-op. You can see that the defect is filled and is reconstructed with Hyalofast. Another patient, this is patellar defect, and the patient has been debrided 12 months before, and it didn't help. He was still symptomatic. He was a very highly active patient. And this is his MRI. This is pre-op. You see in a sagittal view, it looked like a crack, and this is the view 6 months post-op. And you're gonna see on my next MRIs. Usually at 6 months, the regenerate doesn't come already up to the level of the healthy cartilage, but after a year, in most of cases, you see the complete filling of the defect. Again, the same patient, different view. This is pre-op. This is post-op. Again, you see the membrane, the regenerate is still below the level of native cartilage, but after 12 months, it's already there. Another patient, another example of overuse of the microfractures in this patient, or he had 2.2 defect, and I had to do arthrotomy because the defect was not contained. So I had to put additional suture on the Hyalofast membrane to fix it to the synovium, and of course I did full person osteotomy. So this is the osteophyte. As you can see here, the defect was extended way to the medial border of patella, and this is how it looks after 7 months. Another patient, 12 by 20 millimeter defect on the femoral groove. Again, Hyalofast with bone marrow. This is the defect, as you can see here. This is 7 months post-op. You can see that there is very, very tiny little tissue on the defect side, but after 12 months, you see that there is a regrow of the tissue in the defect. Another interesting case: patient has been meniscectomized during the ACL reconstruction, and within a couple of years, he developed large cartilage defect, about 2 centimeter diameter, on the lateral condyle. So this patient has been treated with ActiFit implantation and Hyalofast, at this time with microfractures. So this is the defect, as you can see here. This is the pre-op. This is 6 months post-op. You see the ActiFit scaffold is here, and you can see the cartilage regenerate. And this is after 12 months. Again, this is ActiFit, and this is the surface of the cartilage. Another interesting case, I'm sorry, this is the same case, but this is the sagittal view. You see the defect is here. This is the meniscus before repair. This is meniscal scaffold. This is ActiFit, and you can see the Hyalofast membrane at 6 months, and this is at 12 months. You can see the maturation of the meniscal scaffold. And this is probably the most interesting case. This is the patient with early osteoarthritis, when I also used Hyalofast with microfractures and with high tibial osteotomy. This is the pre-op X-ray. You see the severe malalignment, and this is the alignment after osteotomy. And this is the defect on the medial condyle. It's quite large defect. And this is 6 months post-op. You see tiny little structure in the defect site, and on the coronal view as well. Kissing lesions, of course, very interesting. And I had four patients inside this study that I treated with the bone marrow. This is the pre-op MRI. The patient had 2 ACL surgeries, and she was still complaining on the anterior knee pain. You see severe cartilage defect with large cysts. This is the CT scan pre-op, and I'm going to show you the video. This is so this is the defect. This is femoral groove. This is patella. You see this is application of bone marrow on the femur and here on the patella, and then this is application of the fibrin glue, and after this injecting pressure with the instrument to make the membrane stick to the defect. And this is the same patient. This is 6 months after surgery. As you can see, this is very interesting. I was not touching the subchondral bone, but you can clearly see that the bone cyst disappeared. So this was the bone marrow injection with the hyalofast without debridement. And this is patient, I think it's the last one, the chronic OCD defect treated with hyalofast. And this is sagittal view of this patient. And this is going to be a next video showing the nanopeak that were mentioned today by Professor Behrens. This is the way that you can make the microfractures a little bit smaller. So this is lateral femoral condyle with nanofractures, and I always try to apply when I do microfractures, I try to apply the hyalofast membrane as a dry. I use the half pipe cannula to insert it easily, and you can nicely see how the membrane absorbs the blood from microfractures. So I usually cut the implant into 4 to 8 small little pieces, and I apply it one by one. So by this I can just adjust the scaffold to the shape of the defect, which is not always regular, and I'm not going to make it bigger to make things easier for me. So this is the second part of the scaffold, and this is very easy without using any gas. And this is the dry arthroscopy that is done just without the fluid, and you just simply suck it with the shaper, and you can nicely work. So this is the application of the fibrin glue over the scaffold, so we can make it stable. But the mechanical, the physical properties of this implant are that it's very easy to stick to the bone. So as I said, in some cases you might not use the fibrin glue at all. So this is the final appearance of the defect. And I usually make the stability check with several extensions and flexions of the knee to make sure that the patient can start a rehab on next days without any compromise, without compromising the scaffold. This is the last movie I'm going to show. This is the defect on the patella, which I'm going to fix also arthroscopically. And again, you've seen this before: dry scaffold inserted inside, and I do not use any extension devices. But maybe for larger defects, it's necessary for me. I don't need to do it. So as I said, I put several small pieces of the scaffold, and then after I have it on site, we use the fibrin glue. I think that the patella is most challenging, and also I think for my practice it's very attractive that I can fix those defects without doing microfractures and still making it as an arthroscopic procedure. This is application of the bone marrow over the scaffold. When you harvest the bone marrow, you just need probably a couple of mLs. I usually take about 4 to 5 mLs, and probably use about 1 or 2 mLs when I implant it into the defect like this. But this is the final step, which is the fibrin glue. So, as I mentioned, my tips and tricks for this procedure is I try to apply it as a small pieces, remove the fluid from the joint, and use the cannula to pass the scaffold easily. And after you have the scaffold inside the defect, apply the bone marrow so it can make a clot on the scaffold, and then you might use the fibrin glue to make it more stable. So when you look at the whole group of the patients, you can, within the first 12 months, you can clearly see that all patients significantly improve in all CUS subscores. But when you compare the microfractures and hyalofast and bone marrow microfractures, there isn't much differences within the first 12 months after treatment in all CUS subscales. So this means that these two procedures work as well. But as I said, this is just the first 12 months observation. But remember that you probably lower the risk of forming the osteophytes. So to conclude, the bone marrow or microfracture and hyalofast is a successful procedure for treatment of cartilage defect. The functional and pain scores significantly improve. And finally, coming back to my first questions, to make it even more complex for you, I let you decide whether you use microfractures or cells, or maybe bone marrow and biomaterials. Thank you very much. I'd like to...
Thank you, Dr. Sinaski.
I'd like to acknowledge, just one minute, I'm sorry. I'd like to acknowledge my co-worker, Dr. Anna Krześniak, for helping me, and I'd like to invite you to join Preservation Congress in next month in Warsaw. Thank you.
Yeah, we will come. Promise. 1 minute. Thank you, Sinaski. One of the pearls in your speech was hyaluronic acid with atrophy for meniscal replacement or partial replacement. Good idea, respect to this concept. And Jim, you use hyaluronic for the fractures, right? How many cases you had?
10 naked Achilles tendon I implemented for repair. And they are both published, accepted for publication.
Okay, thank you. Halil, do you have some notes about what do you are the expert in the laboratory, right? You are a friend of us in the operating room, and the industry is here. Do you have one recommendation, not two, please, because we have the time?
Okay. Thank you very much.
I thank you.
Thank you very much for the good presentation also. What I suggest only maybe the use of other components of bone marrow and fibrin glue might be a little high, or because I'm coming from the material science
Laboratory.
Yes, laboratory. That looks a bit more.
Okay, thank you. Maybe one
Maybe
day
you can comment on this.
Okay,
Yes.
thank you. Maybe one day my drummer friend will combine Actifit with hyaluronic acid with René and his son, Junior Verdon. It will be more easy. This is the end of the session. 1 minute, please. I would like to ask Carla, Charles, all my friends speakers, no, please stand up. And Murat Bey, Arif, you have to come here and Hadi, please, one word.
Thank you so much. Yes. Thank you so much for attending. I hope you enjoyed the presentation. You've been handed certificates of attendance. Any one of the speakers or a representative from Anika Therapeutics can sign that to show that you've been here. And again, thank you so much. We really appreciate you being here. Thank you.